All right, so clinical approaches to small cell lung cancer from the medical oncologist's perspective. This isn't going to take a whole hour, I don't think. We'll break and discuss and happy to chat. So I thought, I would initially start this even broader than small cell, just thinking about, how are we doing in the fight against lung cancer defined broadly? And, there was recent data that just came out in the US looking at mortality from various cancers. This paper comes out every year, as you guys probably know. Everyone ends up citing it to emphasize the importance of their favorite disease. I think it's pretty striking. This incredible decline in lung cancer incidence in the United States, and this really reflects, in large part, tobacco utilization with a delay of about 30 years. So, the Surgeon General's report on tobacco came out in 1964, pointing to the clear connection between tobacco use and lung cancer. That began to change habits in this country. And 30 years later, we're beginning to see a real decline. I think there's a future here where lung cancer might not be the leading cause of cancer mortality in the US. I would be really interested to see the worldwide trends, because I think some areas of the world, unfortunately, have not seen the same decline in tobacco use. So what do we attribute this to? I think there are multiple possible reasons for this. The dominant one is clearly tobacco cessation, but other things on the prevention side, asbestos mediation, pollution control, some improved detection. I wish we had CT screening where it ought to be, but unfortunately, that is not the case. So I don't think that's having any real impact. There's probably some impact here from actually better therapies, improvements in surgical technique and radiation delivery, better drugs, better supportive measures. But really, I think this is related to tobacco use. And there's been multiple revolutions, certainly on the therapeutic side in lung cancer. Again, outside of small cell lung cancer, we all know about targeted inhibitors of driver mutations for lung adenocarcinoma and what an impact that has had on subsets of the disease where we do have targets where we can really effectively suppress them. This is a recent study, a few years ago now, in the ALK space, just showing how dramatic this can be. This is comparing lorlatinib to crizotinib. And you can see 3-year survivals here, over 75%. And the lorlatinib curve, by the way, really flattens out. So people get really durable responses on this. This was clearly the first major revolution in lung cancer therapy, starting with EGFR, with the first approvals in 2004 and building from there. Second approval, you guys all know this, immunotherapy really changed the outcome for patients with non-small cell lung cancer in particular, but also small cell. This is a study that was led by Matt Hellman, one of several, looking at first-line metastatic non-small cell lung cancer patients treated with chemotherapy versus combination CTLA-4 and PD-1 directed therapy with ipilimumab and nivolumab, changing the fate of patients with lung cancer really quite impressively. And of course, this led to a Nobel Prize, with Allison really focusing on CTLA-4 and Hanjo focusing on PD-1 as targets a few years ago. The third revolution, and this is one that is still ongoing and in progress, is really disease detection and monitoring. And I think this is going to be a major thing well, it's already become a major thing, but it's going to become really part of our clinical practice in a more robust way in the next 5 years, is blood-based detection analysis. This is one paper I pulled out. This is actually a little bit older now, but this is from Max Dean, who I think is really the leader in this area at Stanford, just showing that after definitive treatment, this was after either surgery or definitive chemo RT, if you check blood-based detection of tumor-specific mutations, you can really prognosticate who is going to have recurrence and who is likely cured with those definitive therapies. And these sorts of assays are getting better and better and better. And I think they're going to become part of our clinical portfolio and probably really transform the field. So where's the future in lung cancer? I think we've seen major advances here over the last couple of decades, really an exciting time to be in lung cancer globally. I think, the curves will shift upward really with efforts at prevention and early detection, stage shifting toward detecting disease very early. I think blood-based methodologies are really going to be central to this. Early interception, the recent studies showing that neoadjuvant chemoradiotherapy for non-small cell lung cancers leads to pathologic complete responses in about 30% of patients is really a breakthrough and I think emphasizes the potential for curing more people with early interception strategies. We're certainly working on better targeted therapies, particularly for the worst actors, like the big one now, of course, is KRAS, and a lot of strategies coming forward there. And novel immunotherapy approaches, immuno-oncology approaches, thinking beyond the T cell. A couple of snapshots here. This is, of course, the first two drugs out of the gate for KRAS and their development from, an initial Nature paper describing that this might be possible in 2013 to approvals for sotorasib and adagrasib. And I would say these are by far not the best inhibitors. We already have second and third generation inhibitors that look much, much better, that are, on inhibitors, that is targeting, the active form of KRAS, targeting other KRAS subtypes, et cetera. And again, you guys know this. And then, immunotherapy, I would just point out to this audience in particular, basically all the successful immunotherapies to date have focused exclusively on this little green cell, right? On CD8 positive T cells, and trying to activate anti-tumor immunity by activating CD8 mediated T cell effectors. But the immune system is big, and there's a lot of effectors here, and there's a lot of territory here for investigation. We have people that are working on macrophages, dendritic cells, natural killer cells, all kinds of stuff. I think the future here is huge. Cell-based immunotherapies, CAR T cells, modified T cell receptors, et cetera. There's a wealth of opportunities here for research and for really changing the paradigm. TIL therapy recently approved for melanoma, really transformative. And I think, we're getting better and better at learning how to give these therapies. So for those of you interested in looking at new directions, I think the broad field of immune effectors, not the narrow focus on CD8 positive T cells, for small cell as well as for other diseases, may be a real opportunity. These are some of the therapies going forward. And this is a paper, just a quick highlight that we published last year, looking at a modified CAR T cell construct. The CAR T alone isn't that effective, but if you give it IL-18 and make it a secreting CAR, an armored CAR, if you will, it's very effective against small cell lung cancer in preclinical models. And this sort of construct, not this precise construct, is actually coming forward to the clinic this year. There was, of course, the initial CAR, anti-DLL3 CAR from Amgen that was tested. Does show efficacy, but I think there's much better CARs in second and third generation that'll be coming forward. All right, so that's all prelude to the real talk, which is focusing on clinical aspects of small cell lung cancer. So this is from a review that we wrote a few years ago. as you all know, small cell lung cancer is probably the solid tumor that is most associated with heavy tobacco exposure. These are typically centrally located tumors near the main airways. They're high-grade neuroendocrine. They, of course, have a strong metastatic predilection, with 2/3 of the cases being metastatic at the time of diagnosis. The primary sites of metastasis shown here, certainly first the local lymph nodes, contralateral lung, brain, very common in small cell lung cancer, liver, adrenals, and bone, in about that order. Of course, this is a tumor that we think of as sort of like the solid tumor leukemia. The CTCs in small cell lung cancer are higher than in any other solid tumor. And as you all know, we can actually use the blood from patients to create xenografts. The tumor is exceptionally proliferative with Ki-67, 80 to 100%, often overgrowing its blood supply, becoming narcotic, and very lethal. There's been changing demographics of small cell, just like there has been for lung cancer overall. And these are curves that I pulled up yesterday from the SEER database, looking at, again, this is US data, which I can easily access. I wish there were this sort of data worldwide, but this is looking at US incidence of small cell lung cancer over time. And you can see the same sort of pretty dramatic decrease in incidence, particularly for males, but also for females since the mid 80s. A pretty striking decline in incidence, again, mostly related to tobacco exposure. I looked at the data by race as well. There's really no particular racial bias, I think, in small cell lung cancer. A little bit more disease per 100,000 patients among white people in America relative to Black, self-identified as such. But really, these curves are very similar and certainly have essentially the same trajectories. The problem with small cell lung cancer, a primary problem, of course, is it's usually metastatic at the time of diagnosis. And you know, if you catch it very early, stage 1, it's actually pretty curable. And patients can actually do quite well with surgical resection for isolated pulmonary nodules, node negative disease. As the stages progress, however, it goes down pretty sharply, and the vast majority of patients, about 70%, unfortunately, are on this stage 4 curve. So these stages are relatively rare. We lump these functionally as clinicians into limited, meaning, you know, focus for local therapies. But really, distinction should be made between really early stage diseases, stage 1 disease, really isolated pulmonary nodules, node negative, versus the more locally advanced stages that tend to be node positive or maybe less resectable, stage 2 and stage 3. How do we approach the various stages? Well, for very early stage small cell lung cancer, isolated pulmonary nodule, stage 1, node negative, the appropriate care here, we think, is definitive local therapy, meaning surgery, or if surgery is not possible because the patient's a heavy smoker, maybe with a lot of underlying emphysema or bronchitis, stereotactic radiation can be given, a definitive dose to really just ablate this tumor. This is actually a reasonable approach. Every patient who gets surgery or ablative radiation should get chemotherapy afterwards, what we call adjuvant chemotherapy, because if you do not give chemotherapy or if you give inadequate chemotherapy, these patients, even though their disease looks to be super early stage resectable disease, they're going to recur. The large majority of them are going to recur. I'm going to pull up a pointer here so that my screen doesn't keep switching. We did a study at Hopkins looking at outcome. It was retrospective of patients that got surgery and then got an older chemotherapy regimen versus what we now give, which is platinum etoposide adjuvant. And it was clear that you really needed the chemo because even in this early stage, we know this tumor is actually metastatic. It's just sort of subclinically metastatic in a lot of the cases. So surgery, adjuvant chemo, many of those patients are cured. We rarely catch it here. Most of the patients who are caught here are kind of caught by accident. They got a CT scan because they were in a car accident or something, and they have a solitary pulmonary nodule. The surgeon takes it out, turns out it's small cell. The more likely scenario for early stage disease is this: pretty large tumor, central located lymph nodes, stage 1 to 3. This would be stage 3. These patients are what we would call locally advanced disease. They're treated with chemotherapy and radiation, and the radiation should encompass all areas of disease. The chemotherapy serves two functions. One, it treats the rest of the body for any micrometastatic disease that is there. That's very important. But it's also a radio enhancer. So it enhances the local efficacy of the radiation, really has two functions. As I'll show you, a fair fraction of these patients, up to a third now, are cured with definitive chemoradiotherapy. Current guidelines are to offer these patients prophylactic cranial irradiation, to give whole brain radiation, low dose, because the brain can be a sanctuary site where the cancer can hang out and recur. And it's been shown in older studies now that prophylactic cranial radiation improves survival for patients with limited stage small cell lung cancer because of the seeding that can occur in the brain. I would say I question those studies a little bit in 2024. We have much better staging methodologies and much more sensitive scans than we used to have. We have high resolution imaging of the brain with MRI, and I'm not sure that PCI is really needed in these patients. We also have better radiation approaches now with very focal radiation, stereotactic radiation with millimeter accuracy if a patient does have isolated brain disease. But this is the current standard of care, and we offer it to our patients. I would say a fair fraction of our patients refuse PCI, not totally unreasonably. PCI, even though it's low dose, the radiation to your brain, it is affected with it is associated with neurocognitive decline and loss of short-term memory and various other problems, fatigue, which can be pretty prolonged. But that would be our standard of care. Most of our patients, of course, are down here. They're stage 4. 70% of the patients have metastatic disease at the time of diagnosis. Standard of care for these patients used to be chemotherapy alone, platinum etoposide. Now it's platinum etoposide with a PD-L1 checkpoint inhibitor that has raised the tail of the curve, as I'll show you. That's our standard of care for anybody who doesn't have a strong contraindication for immunotherapy. And we would really, as clinicians, err on the side of trying the immunotherapy because it's the only therapy that has the potential to lead to durable benefit for these patients. After completing 4 cycles of combined therapy, those patients get maintenance PD-L1 directed therapy as a single agent. There's been controversy about radiating the residual disease in the chest. There were some studies led by Dr. Slotnick in Europe that had shown the potential for benefit in after definitive chemotherapy for first-line small cell lung cancer in the metastatic setting of radiating the chest. That study was technically negative. The primary endpoint was survival at 1 year, and that did not meet the primary endpoint. There were more patients alive at 2 years, however, who got the consolidative radiation. Every statistician will tell you you can't change your endpoint of the study after it's done. But people have looked at those data and used them to offer patients consolidative radiation. I would say my practice, outside of the context of a clinical trial, I don't offer that because there's really no data to support it. It is potentially toxic. And it was done in the era before we had immunotherapy. So we really don't know what to do with consolidative radiation therapy now. I would say it is a research question, not part of our clinical practice. Recurrent disease, it's pretty simple for small cell lung cancer right now. Up until very recently, the only standard of care that was FDA approved was topotecan. This is a topo-1 inhibitor. It's a drug that everyone hates. It makes people really tired. It's pretty toxic. It has a lot of GI toxicity. People feel pretty miserable on it. There's a new player on the block, lurbinectedin. This got an accelerated approval from the FDA. I'll show you the data in support of that. It's really not much better of a drug than topotecan, honestly, but it is less toxic. And so, at least in the US, this has been given as second-line therapy. We're clearly looking for better therapies for recurrent small cell lung cancer or for maintenance. And this is a really active area of research. So limited stage small cell lung cancer, this category of patients kind of in the middle here that gets chemoradiotherapy, there's been major advances in the outcome for these patients. We look back at a study back in the early 90s, really looking at whether chemoradiotherapy could beat chemotherapy alone. And it does. It doesn't beat it by a lot in this study. But you can see that 5-year survival here is in the single digits, maybe up to 10% with combined therapy. Close to a decade later, there's a study that's gotten a lot of press, Teresi et al., looking at daily radiation versus twice daily radiation. In this study, twice daily radiation won out and improved 5-year survival up, closer to 25%. The truth is, either one of these is actually a reasonable regimen, and with current radiotherapy approaches, once daily or twice daily radiation has pretty similar outcome data. And radiation therapists sort of like the once daily radiation approach. In this country, once daily radiation is more common than twice daily radiation. At a lot of academic centers, including Sloan Kettering, we use twice daily radiation based on better outcome in a randomized controlled study here. This is more recent data, and really the most recent definitive phase 3 trial that was conducted in this space. And this did compare once and twice daily radiation. You can see the curves are not statistically different here. But I think the important point is 5-year survivals have improved from the single digits to about a third of the patients having 5-year survival here. And if you're alive at 5 years, you're pretty likely to have beaten the disease. These curves do flatten out. We'll continue to track these data, but I think a lot of these patients are actually cured of their disease. And that's sort of where we are for limited stage small cell. The issues, clinical issues for limited stage, what are the appropriate indications for surgery? I just showed you the chemoradiotherapy data. There really haven't been good studies looking at the benefit of surgery for very early stage disease. I think surgery, honestly, is probably underutilized because it's not part of our standard of care for most of these patients. Patients really might benefit more if we took their cancers out. The cancer that's sitting in the bucket is never going to recur. And so a surgery is probably the most definitive local therapy that you could give, and probably underutilized in this disease for patients who would be otherwise eligible for surgery. But that remains an open question. Is prophylactic cranial irradiation really needed in the era of stereotactic radiation and high quality MRIs? We don't know. There are ongoing studies looking at some approaches such as hippocampal sparing. So this is whole brain prophylactic cranial irradiation, but not radiating the hippocampus, which is a big memory center of the brain. Maybe if we spare the hippocampus, People won't have the short-term memory problems that are ongoing that sort of plague these patients. There's a risk there, though, because if they have microscopic disease in the brain and there's microscopic disease in the hippocampus, we missed it. And then, we've radiated the rest of the brain and given them toxicity with fatigue and everything else, and we actually haven't saved their lives. So it's an open question whether that's the right approach or not. There are some drugs like memantine. This is a drug that has been used for memory loss in conditions like Alzheimer's. It's borderline effective, but it may have some impact actually on reducing the toxicity from whole brain radiation. We'll see. Those studies are difficult to do, but it is something that we're using in patients in the clinic. I think the big question here is, what's the role of immunotherapy in limited stage small cell lung cancer? Immunotherapy has transformed our standard of care for extensive stage disease. Why aren't we using it for patients who have more curable early stage disease? And I think the big questions here, and these are being addressed in current ongoing clinical trials, are, should we be using immunotherapy as maintenance after chemoradiotherapy, or should we overlap it with chemoimmunotherapy and give it in the context of radiation? As you probably know, there's been real interest in the combination of radiation and immunotherapy, with the idea that if you radiate tumors, you shed tumor antigen, it gets picked up by the dendritic cells and carried to the lymph nodes, and maybe there would be a synergistic interaction between radiation and immunotherapy. I would say the clinical data to date across other disease types like non-small cell lung cancer and head and neck cancer is actually pointing in the other direction. That is, that there may be a negative interaction between radiation and immunotherapy that we might want to actually avoid. And that data actually comes, this is data from non-small cell lung cancer. As you probably know, for limited stage or say unresectable locally advanced non-small cell lung cancer, the Pacific regimen has become our standard of care. In this regimen, people get chemoradiotherapy, kind of like we would do for small cell lung cancer, slightly different chemo, but basically the same approach. For small cell, we just give the chemoradiotherapy and stop. This study looked at basically that, chemoradiotherapy and stop, continued placebo, versus giving adjuvant post chemoradiotherapy, durvalumab, a PD-L1 directed therapy. And you can see this really improves outcome. This is looking at progression-free survival. At every point, the durvalumab curve is beating placebo, and this has changed our standard of care here. The hazard ratio of 0.55, quite strong. So the natural question would be, well, why wait on the durva? Why don't you put it up front with the chemoradiotherapy? And of course, the Pacific 2 trial did exactly that. It was basically the same backbone, chemoradiotherapy followed by placebo as a control. They brought the durvalumab up in with the chemoradiotherapy. Controversy about this trial is the control arm is bad because we had already defined that the standard of care ought to be post chemoradiotherapy durvalumab. But in any case, they chose the old control arm, brought the durvalumab up front, and there's a problem. This didn't win. This study is negative. We haven't seen the data yet, but there was a press release that came out in November basically saying it didn't meet its primary endpoint, which was progression-free survival. So there's a problem with bringing durvalumab up into the chemoradiotherapy. I say all this because in small cell lung cancer, there are ongoing trials looking at this strategy, and there are ongoing trials looking at this strategy. And the non-small cell data and the head and neck data actually would suggest that this may be a failed strategy, and this is the better way to go. We'll see. We'll see. Extensive stage small cell lung cancer on the clinical side. Before 2018, our standard of care was a platinum doublet, typically platinum, either carboplatinum or cisplatinum with etoposide. This is a Japanese trial that looked at etoposide. I'm sorry, this is an American trial, actually. etoposide platinum versus irinotecan platinum. You can see identical outcomes here with these two. Both of these curves going to ground, essentially no survivors at 3 years. Really kind of dismal outcome. This is where we are today with the addition of PD-L1 directed drugs like durvalumab. You know, unfortunately, the curves are not separating as much as we would want, but there is a lifting of the tail of the curve. You know, there's a tripling of 3-year survival here from about 5.8% to 17.6%, and the curves flatten out. This curve, you know, doesn't quite go to ground like it used to. Why? Because some of these patients get salvage immunotherapy on the back end and actually benefit from that. So immunotherapy, when it works, can lead to durable responses. A huge research question for our group, for your group, is how can we get this curve higher? How can we stimulate the immune system against the large majority of small cell lung cancers that are not immunoresponsive? And if this were a research talk, I'd talk a lot about that. There's been a lot of trials, Me Too trials in the first line setting. The trial that I've sort of shown you is this one, looking at platinum etoposide versus platinum etoposide with durva. The immunotherapies here are all in blue. They're all basically the same. They're looking at a chemo-IO combo versus chemo alone. There's some additional drugs trying to bring in an additional immunostimulant. But basically, all these trials have very similar outcome data supporting that immunotherapy can benefit people with small cell lung cancer. It benefits them, but unfortunately, it usually doesn't work. The majority of patients don't benefit from immunotherapy. The median improvement in survival is only a couple months. The transformative benefit is in a small subset, and that's reflected in the tail of the curve. It is a super meaningful difference clinically, but for most patients, it doesn't make a difference. It doesn't work. These responses can be durable even after you stop the therapy. This is a trial that I led a few years ago, looking at chemo pembro and then maintenance pembro. On this trial, we actually stopped the immunotherapy after 2 years and looked at outcome. And the interesting thing here is, you know, the patients who complete 2 years of pembrolizumab, not many of the patients got this far, but those that did, actually, the majority of them are still alive 2 years later, off of any therapy, and you know, kind of living their best life. So you can actually benefit these patients in a meaningful way. This is one of my patients who actually is an exceptional responder now out about 9 or 10 years. So this really can effectively put this disease into remission. You know, this is a patient with biopsy-proven metastatic small cell, stopped her therapy about 6 or 7 years ago, and I see her once a year in follow-up. Blocking more of the T cell checkpoints doesn't work, so there have been studies looking at addition of a fourth drug. So platinum etoposide durva, our standard of care, adding tremelimumab, CTLA-4, numerically worse outcome, more toxicity. Same thing when you add TIGIT, another trial that I led, unfortunately negative, no benefit for the addition of hitting the T cell harder. So I think a challenge for this audience is, you know, how do we bring these curves up? So you guys go home and work on that. There's a lot of strategies that are being looked at. As you know, this strategy doesn't work. I already showed you that. There's a lot of interest in this drug, tarlatamab, and similar BiTEs that are coming forward in the clinic now. There's strategies looking at, you know, activating DNA damage response pathways and inflaming the tumor. There's a lot of interest in epigenetic priming, a strategy that our group is particularly focused on. In the BiTE world, there are multiple BiTE molecules, bispecific T cell engagers, that are bringing T cells into connection with small cell lung cancer. These look very different, but they're really all pretty much the same. They have a CD3 binding domain and a DLL3 binding domain, and they basically link the T cell to the tumor. I'm presenting these because I think in the next few months, this drug is going to get approved. So it is going to become part of our standard of care. I hope. We'll see. But I think approval, at least an accelerated approval, is pretty likely. These are the data with tarlatamab that were published recently in the New England Journal. The majority of the patients who do respond, which is about 40% of them, respond right away. So at first scan at 6 weeks, there's already response. And these responses are pretty durable. All of these responses are ongoing. And the initial data suggested a durability of response of over a year. Pretty good for patients with recurrent small cell lung cancer. So I think this is a real drug, again, likely to get approved. There's other drugs in this space, like the Harpoon molecule, very similar data. We're seeing a lot of responses with this, a lot of benefit in small cell. Antibody drug conjugates are active here. The two at the bottom in particular, anti-CD276, which is B7H3, and anti-SEZ6, pretty likely, I think, to show some benefit. Early data with the B7H3 antibody drug conjugate, you see the patients with small cell lung cancer, the majority of them benefiting. We're leading this trial right now, looking at doses for this drug. I will tell you the 12 milligram per kilogram dose is going forward with another 100 patients, and I would say the initial data looks promising. The other drug that we have that's an accelerated approval for recurrent small cells, lurbinectedin. This is an interesting drug. It's actually a synthetic derivative isolated from a sea sponge. So, you know, an argument for maintaining biodiversity in our planet is that we can find these drugs naturally. You know, it's been described in a lot of different ways. It does have effect on transcription factors like ASCL1, NeuroD1. Really, it's an alkylating agent. It modifies both protein and DNA. I'm not sure it's that special as a transcriptional inhibitor, but that's how it's been described. The response rate in patients with small cell lung cancer is about 35%. Median survival, 9.5 months. For recurrent small cell lung cancer, again, not bad. The major advantage over topotecan, again, is it's less toxic. I'll show you those data in a second. This is sort of the outcome data for the 105 patient trial that got this an accelerated approval. They do need to do a confirmatory phase 3 to get this drug a full FDA approval in the US, and certainly for approvals elsewhere around the world. They'll need better data than what they have here. The initial phase 3 that they did was actually negative. It looked at a combination of lurbinectedin with irinotecan, which was, or with doxycycline, which is actually not a great strategy. There's probably better combinations coming forward. We'll see, but this is a reasonable drug. It is I would say it's a single, not a home run. Again, the major advantage is on toxicity. This is comparing the toxicity of lurbinectedin in that 105 patient single arm phase 2 trial versus topotecan in some older trials, one of which had the addition of GCSF, one of which didn't. You can see febrile neutropenia, similar if you give GCSF, but much better than topotecan if you don't, and less anemia, less leukopenia, less neutropenia, less thrombocytopenia than topotecan alone. So a better toxicity profile, but unfortunately not particularly more effective for treating disease. So that's where we are. This is small cell treatment by stage. Again, a relatively simple schema, I think. Stage 1A, if possible, we resect. We give adjuvant chemo. More locally advanced disease, we give chemoradiotherapy. And we currently recommend giving prophylactic cranial radiation, although I would say I'm dubious about its benefit. Extensive stage disease, we give chemoimmunotherapy, maintenance immunotherapy. I don't give consolidative RT, although some people do. And then for recurrence, we actually only have 2 approved drugs, topotecan and a accelerated approval, meaning not a full approval, for lurbinectedin available in the US. And just in closing, I would say the true standard of care for patients with small cell lung cancer should be a clinical trial, if at all possible. All of these standards of care, I think, are suboptimal. And the cutting edge of research that our groups collectively around the world are doing in this space are bringing new ideas forward. Those ideas need to be brought to the clinic because the current outcome for this disease is still pretty dismal. All right, I'm going to stop there. I'm going to stop sharing. And again, thank you for bringing this group together. I hope this was helpful as sort of a primer, clinical primer. Happy to share the slides. No secrets here. And